Thank you for joining this presentation. My name is Martijn Starmans. I'm a PhD student from the Erasmus Medical Center in Rotterdam, the Netherlands, and I will tell you a little bit today about my work on distinguishing well-differentiated liposarcomas from lipomas on MR using a radiomics approach. So I have no conflicts of interest to disclose. So we're concerned about two types of tumors here. On one hand, we have well-differentiated liposarcomas, and these malignant tumors are a large subgroup of sarcoma and often require some form of treatment, such as surgery. On the other hand, we have the benign lipoma, and while you can distinguish these using an invasive biopsy, visually it's quite challenging to distinguish the two. However, an accurate diagnosis is required in order to pick the correct treatment. Therefore, the goal of this study is to find a non-invasive method to distinguish these tumors using radiomics based on MRI. So let's first take a look at the dataset that we're using here. So we're using a dataset consisting of 116 patients. Half of the patients are well-differentiated liposarcomas and half lipomas, and these are all patients referred to our hospital. So for all of these patients, we have at least a T1-weighted MRI, but additional sequences might be available. And while these patients were all referred to our hospital, the scans originate from different hospitals, so there's quite some variation in the acquisition protocols. So for example, on the table left, you can see that there's some variation in the parameters for the T1-weighted MRI. For all these patients, the ground truth was found by looking at the MDM2 amplification. Next, we're looking at the radiomics method we're using. So suppose we start with the T1 images. And the first step is that the clinician manually segmented all the tumors on these images. Suppose we use an additional T2 sequence, then we don't use manual annotation to segment these tumors, but we use image registration to warp the segmentation from the T1 image to the T2 image. Next, for each of these sequences, we extract some features which describe these tumors. So these might be simple descriptors, such as by looking at the intensity and the mean intensity of a tumor, for example. Looking at shape, so for example, whether a tumor looks more like a circle or like a star, but also more complex features, so some texture features, for example, which describe the heterogeneity of a tumor. And we do this for all of the patients, and for all of these patients, we know whether a tumor was a well-differentiated liposarcoma or a lipoma. Next, we are going to use machine learning and some pre-processing methods to create a decision model. However, there's a wide variety of methods available, and we don't know beforehand which one will work best. So therefore, we have collected a whole bunch of machine learning and pre-processing methods, and we use automatic algorithm optimization to determine which combination of methods will give us the best prediction model to distinguish between well-differentiated liposarcomas and lipomas. So some results. So in all these experiments, I used a 100 times random split cross-validation to make sure we separate the part that we train the model on and we test the model on. So on the top left, you can see the ROC curve of our models. So the blue curve is when we only use the T1 scan, and in the table you can see the exact performance. So for example, AUC is 0.83, and you can see that when we add a T2 sequence, the performance improves a bit. We also asked 3 radiologists to manually score all these patients and had access to the T1 scan, the T2 scan, all other sequences, age and gender, and their performance is also plotted in this image. So you can see that their performance is similar or for 2 radiologists a bit below the curve. And what's also important to note is that the agreement between these radiologists is pretty poor. So while the performance is quite similar, if you look at an individual patient, they only seldomly agree whether it's actually a lipoma or well-differentiated liposarcoma. So what can we conclude from these results? Well, we saw that radiomics can actually distinguish well-differentiated liposarcomas from lipomas. We also saw that the performance is superior to 3 experienced radiologists. And while the radiologists have a poor agreement, the radiomics model is more objective because it will also always give the same result on a sequence. So what can you use this model for? Well, you could obviously use it in a diagnostic workup of these patients, so to distinguish between these 2 tumors. But you might also use it in the patient selection for a clinical trial, for example. So if you only want to include well-differentiated liposarcomas, you don't have to do a biopsy and bring risk to the patient, but can use this non-invasive method. Of course, there are also some limitations to this study. So first of all, while we did use a multi-center dataset, external validation is required to validate our findings. Second, we currently rely on manual segmentations for this model, which is not feasible in clinical practice, but this might be solved with an automatic segmentation method, for example using deep learning. And lastly, this variation in imaging protocols might have influenced our performance. However, since we trained the model on different imaging protocols, we can also apply it on different imaging protocols. Here's my ethics and funding information. And last but not least, this method that we use to automatically find the optimal radiomics method is open source. It's very easy to use because it automatically finds the right method, and it's a very generic solution. So for example, in ECR this year and previous year, we've demonstrated that it works quite well on a wide variation of clinical applications. So if you want to try it out, a link to the software is here, and you can always contact me if you have questions. Thank you very much for joining this presentation.